evening, and welcome again to Public Perspective. I'm your host, Kevin McDermott. And tonight we'll be veering off a little bit on a tangent from our usual topics. Tonight we're going to be delving deep into medical science. Our guest tonight is Dr. Kousic Krishnan, who is a cardiac electrophysiologist at Rush University Medical Center. Dr. Krishnan, it's a pleasure to have you here.
Thank you very much.
So that was a mouthful. I hope you appreciate the fact that I got all of that out without stumbling on it.
You didn't mess it up at all.
Well, thank you. So let's tell our viewers, what is a cardiac electrophysiologist?
So we can abbreviate it these days to EP, but it's a subspecialty of cardiology where the heart now, just like in your own home, you call a plumber for a plumbing problem. If it's an electrical problem, you call an electrician. The heart has those same kind of systems, and so now we're so specialized that if it's an electrical problem, you'll call someone that's a cardiac electrophysiologist to help diagnose and manage and treat a problem that deals with the electrical system of the heart.
So one of the things I as you know, I'm a layperson, not a scientist, or certainly not a doctor, but I do read about complexity in lots of different fields, engineering, information technology, and medicine. And one of the things that comes up is the idea that with specialties, there are always areas that happen outside the specialty. And how do you as a specialist, especially as these specialties become more and more refined, how do you remain aware of the other areas around you so that you know when to call for help or when something, when something might be connected that you might not even realize? Right.
I mean, I think of it as kind of like if you zoom out, like we're kind of focused on one part of the heart, and that's the electrical system. You zoom out, talking about the whole heart as a unit. And cardiac electrophysiologists are cardiologists as well. We trained in cardiology. We remain board certified in cardiology, so we do still have to have a full awareness of how the whole heart works. So that segment, we zoom back one level to cardiology. We're still cardiologists at heart, and our training was in cardiology, then we just became subspecialized. If you zoom out one level further, the specialty that kind of branches off into all the different specialties, it's called internal medicine. So internal medicine encompasses gastroenterology, rheumatology, allergy, cardiology, and so we do still keep in touch with internal medicine through continuing education, through conferences, through our own hospital, we're going to grand rounds. So even though we're subspecialized, we kind of have our DNA as an internist that just decided that we had a special interest in one particular area of this large field of internal medicine and decided to make that our life's work, but that our underlying knowledge base is still to have a broad knowledge of the whole body as a whole.
Because it's the body, as you know, is an integrated system.
Yes.
So you need to know as much about that system from a systemic standpoint as you can, right?
Absolutely.
So cardiac electrophysiology is the study of the electrical aspects of cardiology. So most people I think are surprised to think of the body as being run as an electrical network. But I think the more we recognize about it, the more we realize that, electricity runs a lot of things inside the body. So how does the electrical system in the heart, for example, your specialty, compare to the wiring in a house?
It's very similar. I mean, I'm biased. I feel like the electrical system is the most important part of the heart, but the heart is a pump, but it derives no ability to pump without the electrical system. The electrical system is what makes the muscle cells contract, providing velocity and contraction of the blood of the muscle, which then sends blood to your body and all your organs. So if you have no electrical system, the pump cannot work. There is just no ability for the pump, for any of those cells in the heart to know that it needs to contract and create, movement of blood without the electrical system. So the electrical system is kind of an intrinsic part of the heart that is through the top and the bottom chamber, and it sends the signals to the proper locations, signaling the muscle, which is the pump, to actually pump.
Now, what powers this thing? We don't have big batteries chunked inside of us. We don't have to plug into the wall at night. So where does that power source come from?
It's a really kind of elegant system because, like intuitively you think, well, it's got to come from somewhere. Like, what is making that electrical system start? Like, is it like? It's not like a spark plug. It's not like a pilot light. Like, what's making it happen? The reality is there are small little kind of nodes of cells in the heart that are constantly firing spontaneously, and they're getting their energy from what every cell in the body gets their energy from: glucose or the food that you take in, makes its way to these cells. But these cells, the unique property of them, they're called pacemaker cells, that they know to intrinsically start to beat. And when that cell beats, it sends electricity down these electrical wires, for lack of a better word, through the muscular system of the heart, and then causes each cell to contract. And then each cell is connected to each other cell, so almost like a wave front, like a wave, like you see in when you're at the United Center and people start a wave, that once the electrical system reaches one cell, it can reach all the other cells as a wave front of electrical
So
activation.
it does not have to be a continuous electrical signal. It starts this wave function, which in fact propagates throughout whatever remaining cells need to be affected by it, right?
But the pacemaker cell is the most important cell, because that one has to know how to beat and set off a signal on its own. Every other cell gets its signal from that cell, so their job is easier. They're just waiting to see electricity come toward it and then contract. But this pacemaker cell has to know to contract on its own without some other stimulus.
And I assume that it fires continuously. That's why we have regular heartbeat.
Yes.
Whatever your heart rate is for any individual.
Right.
So do these pacemaker cells fail from time to time? Is that what can cause heart problems?
Right, absolutely. So the electrical system, when it fails, the heart rate usually goes very slow. Or if it doesn't go dangerously slow, it goes slow enough that it's not enough to supply the needs of the body. Your body, when you walk around, you exercise, you need more when you're exercising than when you're sleeping. Your heart rate is slower when you're sleeping. It's much higher when you're on a treadmill or running outside. So when the electrical system fails, the heart rate usually goes very slow. And right now, we have no treatment to make the pacemaker cells of the heart regenerate themselves. There's research on that maybe in a few years or a decade, who knows, we may be able to inject cells that can take over like a normal electrical system. But right now, if someone's heart fails from an electrical standpoint, and it's because their heart's going too slow, we insert something called a pacemaker, and that will restore the heart rate to a normal level and give them their quality of life back.
And if these pacemaker cells start firing too fast, we were talking before the show about atrial fibrillation. Are these cells involved in that as well?
Similar to that, it is a fast rhythm coming from the top chamber, but there's also fast rhythms that come from the bottom chamber that are more dangerous. Those we treat with a device called a defibrillator, which shocks the heart. You see defibrillators all over the place. You go to the mall,
airplanes,
they're AEDs, they're automatic external defibrillators, but those are miniaturized, and for people that are at very high risk for dying from a life-threatening rhythm problem, we'll implant a defibrillator so that it's there when they have a problem. And when you have these AEDs, they are fine for public locations, because people that are in public locations, most of them are not going to go into cardiac arrest. And when they do, it requires someone else to act. Like the person that's going into cardiac arrest can't reach to the wall, open it up, put it on themselves, and save their life. It requires some other person to be there to notice that they're in cardiac arrest, get it off the wall, and then put the patches on and get them out of it. These defibrillators are automatic, the ones that we install inside of the body. So they're automatic. They don't require anyone to be involved, other than, they don't require anyone. The device itself knows what to do. Atrial fibrillation that you mentioned is the top chamber of the heart going faster, and that comes with aging, high blood pressure, diabetes, people that have vascular disease. Women are more at risk for atrial fibrillation than men.
And fibrillation just means an irregular beat? Is that
right? Fibrillating is almost like quivering. So the top chamber is, looks like a quivering bag of worms. It just doesn't.
That's
just
a very
doesn't
unappealing concept.
Yeah,
right?
it is.
Yeah.
But it helps understand a little bit, or describe why some of the consequences of atrial fibrillation are what they are. Is when the top chamber is quivering, it's not contracting forcefully like a normal top chamber should. And that quivering, it means that blood does not go through that chamber with the same speed or velocity that it does when the upper chamber is beating with a normal contraction.
Now, you're talking about the chambers, and fortunately we have this wonderful model right here.
Yes.
Now we've got a model here with 3 doors, which I think is ever so convenient. Right, so there's the heart, and then we have, 2 chambers here, a chamber here, and a chamber here as well, correct?
Correct. So we have 4 chambers, even though there's only 3 doors. We have 2 lower pumping chambers. These are called ventricles, and they are really the most important part of the heart. They supply the blood to the organs that they're meant to supply. The right side will supply blood to the lungs, so it takes blood that's been taken, the oxygen's been taken out of it by your muscles, and it comes back to the heart, and it needs to be sent to the lungs so that it can get recharged again with oxygen. Then it comes back into the left side of the heart, and the left ventricle is the big pumping chamber. That sends blood to every part of your body, every organ, and it's the most important chamber. The top chambers are called atria, singular is atrium, and these are more like receiving chambers. They do have a small role in pumping blood to the bigger chambers, but they don't have any role in actually pumping blood to your organs or to your lungs. But they're very important because they help fill the blood into the main pumping chambers, and when there's disorders of those upper chambers, that's where clots can form and people can have strokes.
So this over here, this is the atrial chamber that you're talking about, where this atrial fibrillation would take place up here in this area, right?
In either one of these, but the left atrium is the more clinically damaging part of the heart to have atrial fibrillation, because this is directly connected to the ventricle, which directly connects to your brain. On this side, if you have a clot that forms, even if it's a tiny one, will just get filtered out in the lungs. Not that that can't have consequences as well, but usually they're not nearly as devastating as a clot that's in the left atrium, because its natural tendency is to go to the brain. The brain gets a lot of blood flow naturally, it provides a very important function in our body, so it demands a lot of blood flow. So when blood is leaving the heart, there are certain organs that get more blood flow disproportionately to their size. And the kidney gets a lot of blood flow, and the brain gets a lot of blood flow. So if a clot forms in the heart and you had to statistically kind of predict where would it go, more often than not, it's going to go to the brain.
And that causes a stroke.
Causes a stroke.
So blood clots form up here because this particular left atrium is malfunctioning, right? It's just,
Correct.
And I take it that there's not a good way today to reconstruct this or retrain it to function correctly, or is there?
No, for some people, we can try to fix the rhythm problem, that atrial fibrillation. Actually go in and try to either shock the heart back into normal rhythm or do a procedure called an ablation, where you burn away some of the misfiring circuits. But none of these are cures for atrial fibrillation. They really control the atrial fibrillation to make people less symptomatic, have less palpitations, shortness of breath, fatigue, things that people will get with atrial fibrillation. But they don't really address the issue of the stroke risk, which is a separate problem from treating the actual rhythm. And it's kind of counterintuitive. It seems like the two should be related together. And obviously, if you're in AFib, you're at higher risk for having clots than when you're not in AFib. But because no therapy we have can cure you of atrial fibrillation, we know that people are still going to go in and out of atrial fibrillation at points in their life. And so you don't know when those times are going to be. They could be for 5 minutes a day, they could be 5 minutes a week, and during those 5 minutes they could form a clot and have a stroke. And so if we knew with some kind of precision when someone was going to go into AFib, or if we had a therapy that could completely eliminate atrial fibrillation, we really wouldn't need to talk about preventing stroke, because we would get to the root of the problem, fix that part of the problem, and then never have AFib again.
But that's somewhere down the road in the future, right?
Correct. So right now, the best that we can do is we try to prevent stroke by preventing the clots. The clots are the problem, and the atrial fibrillation is the source of creating the clot, but if we can't get it at its source, we can say, well, how do we deal with the clot? How do we deal with preventing the clot? And up until very recently, really the only way for us to prevent a clot was to thin blood with medications. And up until about 4 years ago, there was one medication, and it was called warfarin, or a lot of people know it as Coumadin. It was actually developed in Wisconsin, and it's actually a rat poison. That's what it is.
That's a scary thought.
It
So
is
we take
scary,
rat poison
and people
to
use
cure
it
us.
every day.
Yeah.
Millions of people are on a rat poison. But the problem with blood thinners are they're very effective at thinning blood and reducing the risk for stroke, almost 70%. But they also thin the blood, so people are going to be more prone to bleeding.
Because if the thinner blood won't clot up enough to
Correct.
heal a scar or a wound, correct?
Right. So it could be a little nuisance bleeding. You cut yourself shaving, or you bang your finger. That's a little bit of a nuisance. You'll get over it. But if you have a colon cancer, if you have an ulcer, if you have gastritis where you have inflammation of the stomach lining, or if you fall and hit your head and a tiny little blood vessel breaks and your own body with no blood thinner would have sealed it off just within a couple of seconds. But when you're on a blood thinner, it just keeps oozing blood, and then it collects around the brain and causes massive swelling in the brain, and people can die from it. So the problem is, the older you are, the more at risk you are for having a stroke. That's one of the risk factors for stroke in atrial fibrillation is age. The other problem is that the bleeding risk goes up when you age as well. So
because of the blood thinner, or just normally?
Just normally, because people have more likely to have cancer when they're older, they're more likely to have ulcers when they're older, they're more likely to be unstable and potentially fall when they're older. Granted, you could have a high-risk occupation as a young person, be a race car driver, and you could definitely be at high risk for bleeding in that situation.
Especially
but on
if you
average,
crash, right?
Yeah, especially. So it's a dilemma, because the medicine that you want to use is needed because as they get older, they need it more and more, but then the treatment itself carries more risk as they get older as well. And sometimes you have to take people off blood thinners because they bleed. And then you're helping them with their bleeding risk, but you are exposing them to stroke risk. And it's a real tough decision for some patients. A lot of people can take these blood thinners fine, some can't, and then you're having to kind of, for lack of a better word, pick your poison. Do you treat the bleeding, or do you treat the stroke?
Rat poison or stroke poison, right?
Right.
So before the show, you were showing me an ingenious little device that helps to approach this problem, and actually not from the left atrium, but from the right atrium, right?
From the left.
Is it from the left?
Yeah.
Okay. So if you have that handy, let's see if we can take a look at that.
All right, I'll kind of show it, I guess, first, just so you can kind of see from the outer surface. This would be the surface of this device that would be exposed to the inside of the heart.
And I should tell people, it's like a little, you described it earlier as a little umbrella almost.
Yes. And it's almost like fabric that promotes a scaffolding for your body to form scar tissue. The back side of it is a very compliant metal that is a memory metal, so it has a shape that it's meant to be, and it stays in that shape. So this device, called a left atrial appendage occluder, goes into, if we look to the model now, in the left atrium, there's a section of the atrium that we call an appendage. And it sounds like appendix, and it kind of is a little bit like an appendix. It's a structure that doesn't have a huge role in our bodies anymore, but we have it in our bodies. But it's unfortunate because it's an area where 90% of the clots form. It's a little pouch. And if you can think of a pouch, if the blood's not going through that pouch very vigorously, it'll stagnate and a little clot forms. And then if that clot stays there, that's not a problem. But when the clot leaves, that's when you get a problem. So rather than treat the whole body with a blood thinner, thin your whole body's blood, not just the blood in this small little area in your left atrium, but your whole body's blood, what if we had a way to actually seal off that appendage so that blood didn't get in or out, and then the source of the clots was kind of
Walled
walled off, like drywall, like you just, it's behind the wall, but it's not going to cause any problems. So this device collapses down into a device called a sheath. It's like a straw. We insert that through a vein in the leg. We guide it up through the large vein below the heart called the inferior vena cava. We guide it up into the right atrium. We poke a small hole between the right atrium and the left atrium. We get that straw into that pouch, and then we pull the straw back, and then this device kind of gets exposed.
It sort of inflates itself.
Yes,
unfolds itself.
Unfolds itself into the shape that we have here, and then it stays in the opening of that pouch. And what happens over the period of several weeks is that your body forms a skin over it and scar tissue, and kind of just like drywall, it just forms it over it, and then everything that's behind it is no longer visible, no longer communicates with the heart, and so blood can't get into that little pouch, and if blood can't get into the pouch, it can't form a clot in there.
And the clots that might already be there can't get out.
Right. And usually when we're putting this device in, we do an ultrasound to make sure there's actually not a clot in there, because we wouldn't want to put it in when there's a clot, because we could possibly dislodge the clot. So the benefit of this device over the lifetime of an individual is that they get the benefit of reducing their stroke risk with this device by sealing off that appendage. But they don't have to take a medicine that has risk that accumulates over time for the rest of their life to do that.
Right, and there are no medical or medicinal side effects from this because it's not a medicine.
Right.
It's a physical thing.
Right.
And what I find most fascinating about that is that it uses the body's own essentially defense mechanism. When you say it forms scar tissue over this scaffolding,
Yes.
that the scar tissue is a normal bodily response to something, and so
Right.
it's asking the body to trigger something that it would normally do anyway,
Right.
and that solves the problem. And it's a wonderfully simple solution to a
Yeah.
complex problem.
Yeah, it really harnesses the body's own mechanism of, like you said, forming scar tissue for a good purpose. You know, in a lot of other places we don't like scar tissue. You cut yourself and you form a scar. It's unsightly. You don't like it. But here, it actually can be used for good.
So there's another device that I found just as fascinating that you have in this little vial back here. Here we go. So this is teeny tiny, and we'll see if our cameras can actually get a shot of this. It's a microchip encased in plastic. Right?
Yes. It's a pressure sensor, and I'm holding it by a little metal wing, and there's another metal wing on the other side, and these are meant to help buttress it into the blood vessel. So this is used for patients with congestive heart failure, which is a very dangerous condition. People build up fluid in their lungs, can't breathe, and often end up in the hospital. A lot of times get readmitted over and over to the hospital because the fluid keeps building up. And not only is it difficult for patients, but it's also a very difficult thing for our medical system. It utilizes a lot of resources, a lot of financial resources to keep people out of the hospital or treat them in the hospital. So the problem is that if you rely on a patient's symptoms to tell you when they're going into a heart failure exacerbation,
Or when this pressure is building up inside.
right, it's almost too late. At that point, they almost have to be in the hospital to get better. You can't reverse it quickly from home. So, but there are signs and symptoms that are subtle that you can't tell, but you can't tell it from home. But what you can tell is when the pressures inside of the heart start to rise, that's the beginning of a heart failure exacerbation. So you can catch it very early if you can measure the pressures in the heart. And up until this device was developed, the only way you could do that was through an invasive procedure. You had to come in the hospital, stick a needle in the vein, guide a catheter into the heart, through the heart, into the lungs, measure pressures, and then realize, okay, the pressures are elevated, let's modify your medications. It's not feasible to do that at home.
Even if you wanted to.
Even if you wanted to somehow perform a procedure on yourself.
Yes.
But this device is a pressure sensor, so yes, it does have to be inserted into the body through a very minimally invasive procedure. It takes about 30 minutes to do. You go home the same day. But this device is measuring pressure.
Now this sits in the lungs, right? Not in the heart itself.
It sits in something called a pulmonary artery, but it's a branch of an artery that sits in the lung. And so this is where you would measure pressure if we were going to do it invasively. And so this communicates with a sensor that is on a pillow. And this pillow would be sitting in your patient's house, either on their bed or in their couch. And all we ask is that every day spend a little bit of time on that pillow. You go and spend 5 minutes when you're watching TV, put it on your recliner. And what that does is that pillow sensor wakes up the pressure sensor in this device. And it says to record a pressure. And it'll record the pressure every day as long as they lay on that pillow. And then once they lay on that pillow, this sends the pressure reading to that pillow sensor. And that pillow sensor is wirelessly connected to a server where all this data is collected. And so I can log in on the computer, and if I have Mrs. Smith, and I can see day to day what her pressures are doing.
So I could be at home with that thing inserted in my lung, and all I have to do is sit on this pillow or lie against this pillow for 5 minutes a day, and you could be literally on the other side of the world, and you would know exactly what's going on with the pressure building up inside of me. That's remarkable. I just have to say that's remarkable.
And I could probably, the reason for this is that I would be able to see subtle changes starting to occur before you would feel symptoms and give you a preemptive strike, so to speak, of giving you a little bit of an extra of a water pill that will then reduce that pressure so that it doesn't build up till you're finally short of breath, and then you're calling me and saying, I'm short of breath, and I say, go to the ER, because at this point,
you're in trouble.
You're in trouble. We need to get 5 liters of fluid off of you, not just, a couple of quarts. And so by seeing the pressure go up, I'm at the stage where I can just get an extra quart of fluid off of you and you'll be back to being where you need to be, versus building up 5 pounds of weight and we have to get off 5 liters of fluid before you're going to feel well again.
And that's what I love about that is that everybody wins. I, as a patient, would not have to come into the hospital, so all those hospital expenses are eliminated.
Right.
Certainly, from my own perspective as a patient, I would say, well, gee, I don't have to go to the hospital, number one.
Right.
And number two, I'm not going to get to the point where I'm short of breath or I'm really in trouble. So this is wonderful. This seems like everybody wins with this. Are there any side effects or any drawbacks?
You have to be on a mild blood thinner when this is inserted. And with the other device, you have to be on blood thinners for a few weeks. This one, because it's sitting in a blood vessel where the blood flow in general is not as vigorous, you don't want clots to form on that device. So it's not a strong blood thinner, but you have to be on a milder blood thinner kind of indefinitely with that.
Permanently,
Yes.
essentially. And this device, we were talking about this before the show, there's a tiny battery in there.
Yes.
And I know people can't see this, and I'm not going to hold it up again for the camera, but this thing is so tiny, you can barely see the size of the microchip. And in there is an even tinier battery that, as you say, lasts for many years, 20, 30 decades.
Yes.
Right.
The reality is, unfortunately, people that need this device are people with more advanced heart failure. And these are people that, in general, probably don't have decades of life to begin with.
Right.
And so this is meant for people kind of at the end stage. Right now, it's only FDA approved for people with the more advanced forms of heart failure, the ones that actually would be in and out of the hospital more frequently. There are people that have heart failure that are still running 2 miles a day that you wouldn't even know they have heart failure. This is not a device for that person because they're not actually in heart failure very much, but it's much more for the advanced heart failure patient.
And I think you mentioned that this has just been approved by the FDA just within the last month or so, correct?
The left atrial appendage device was approved at the middle of April. This other device is called CardioMEMS. That's been out on the market for about 9 months now.
So we're really talking about the state of the art here,
Yes.
right? Does this make you very excited as a cardiologist?
Well, I mean, it is because, I failed to mention I was an engineer before I went to medical school, so I have, I like technology, and that's part of the reason I chose the field that I did, because I get to do things with my hands, I get to, operate, I get to, do invasive procedures, but I also like the intellectual part of it, that, that there are solutions where probably someone in the computer field that, saw that how we can miniaturize these pressure sensors, or someone in the mechanical engineering, electrical engineering. I mean, that's really a mix of mechanical engineering with pressure sensors and electrical engineering, battery technology, miniaturized to a point where it can be permanently inserted in a person's body and be there for the rest of their life.
Not to mention material science, because you have to build it out of materials that are not going to cause adverse reactions, right?
Absolutely.
So believe it or not, we're actually about out of time here. But this has been fascinating, and I want to thank you for bringing in such a great model and educating certainly me, and I trust our viewers as well, on what's going on and what we can do to help keep ourselves healthy as we go forward. So Dr. Krishnan, thank you so much. I appreciate your coming in and spending time with us.
You're very welcome. Thank you.
And thank you for joining us once again on Public Perspective. I'm your host, Kevin McDermott. You can find us every Saturday night at 8 on Comcast Channel 19, and you can find us on the web at publicperspective.tv. So until next time, thank you and good night.